This session is called Mind the Gaps. And one of the things that you would have seen in the film is how complicated our systems can be for patients to navigate through. So this is just a part of CPFT. So if we look at, this is the gateway into CPFT, and then patients have to navigate through this entire maze, and it can be quite difficult. So a question arises as to what we can do to simplify the process and how, working with partners across Cambridgeshire and Peterborough, things could be simplified. One of the things that has happened is that there is increasing demand and there are constraints on capacity year on year. So for example, when the bed stock reduced and we introduced the 333 system, we introduced a system in which an assessment unit would deal with 70% of the patients who are coming in 3 days' time. The reality is in 3 days' time, you can't treat anything. But you can assess someone, you can get them to a state where they feel hope and a sense of agency, but they still need their treatment. They need their treatment in home treatment. So what automatically happens is home treatment aligns themselves up to the inpatient system. They are meant to be an alternative to admission anyway, but the alignment gets stronger, which means that they get further away from the locality teams, opening up this gap in between. Now, the home treatment has a way of going red, amber, green, stratifying patients based on the level of risk that they're dealing with. Similarly, the locality teams would have a red, amber, green. As the gaps open up, what happens is the red of a locality team is much lower than the green of the home treatment team. So patients start to fall through these gaps. And these gaps open up between locality teams and IAPTs as well, or primary care, GP land. GPs are under tremendous pressure. So there is a gap that opens up at that end. So in other words, if we just blew the locality team up into the various pathways like the affective disorders pathway and the psychosis pathway, what you find is that you can have people who are being assessed, but then from assessment to get onto the treatment, there is a waiting time in between. So patients who might need benefit from psychological interventions, we just end up giving more and more medication, and patients then wait in this gap, and then crisis happens, and then they fall through the gap between the locality teams and the crisis teams. In a similar way, for patients with personality disorder, there's a gap at this end. There's also a gap at that end to primary care to step patients down. And similar kind of way for psychosis pathway. So a lot of what we would hear today in this session is about how working together with our commissioners, with the police, with our ambulance services, with county council, with our third sector colleagues, we can start closing these gaps. Because the reality is that if we want to eliminate force, and by force I mean a very broad construct, then we have to intervene early, we have to assess early, we have to carry out rapid responses so that a patient never gets so unwell that they have to give up the driving seat. They give up the driving seat when they are so unwell that they lose insight. So if working together, we can make these pathways seamless, and we will hear a lot about that, we will hear about the innovation that's happening, and we'll hear about different perspectives. And there are unique partnerships that we can form which can make this pathway seamless. And that's what we are hoping we will capture through the Promise Charter. Thank you.